This lecture is on nursing considerations for insulin administration for the management of diabetes. All patients with type 1 diabetes take insulin, while some patients with type 2 diabetes require insulin. This lecture is number 5 of 8 lectures on diabetes. By the end of this lecture, you should be able to answer what are the nursing considerations in the administration of insulin for the management of diabetes. This slide shows the natural ebb and flow of blood glucose levels and natural insulin secretion in a healthy individual. The first figure shows blood glucose levels in red on the y-axis or the vertical axis here. On the horizontal axis or x-axis is time over a 24-hour period over here. As you can see, the blood glucose levels stay below 100 and peaks after breakfast, lunch, and dinner. In the second figure here, you can see the insulin levels in green. The insulin level is never zero because the healthy pancreas always maintains a basal or a minimal level of insulin throughout the day. You can see that the insulin level peaks in response to mealtimes. At mealtimes, there is a sharp increase in insulin secretion in response to the increase in blood glucose levels. A typical or an ideal insulin regimen is one that mimics the natural physiology as seen in the previous slide. So, a typical approach to the medical management of diabetes is using a combination of long or intermediate acting insulin to provide basal insulin. And in addition to a long or intermediate acting insulin, a rapid or short acting insulin is injected at mealtimes to cover rising glucose after meals. The the intermediate or long acting insulin would typically be fixed in units. The short or rapid acting insulin is typically administered using what's called a sliding scale. How much regular or rapid insulin should you give? The typical answer is a sliding scale. This is just an example of a sliding scale. Sliding scales vary from patient to patient, but this one is an example. Remember in lecture 4, we said that AccuCheck is done 4 times, specifically before each meal and at bedtime. So using this table, if you check your patient's blood sugar and it is 150, then you do not need to administer insulin. If AccuCheck is 186, then you need to administer 1 unit. If AccuCheck is between 200 and 250, then you need to inject 2 units, and so on and so forth. This is what's called a sliding scale. So, how much insulin to inject? Intermediate and long acting insulin is typically given in fixed units. Short or rapid acting is typically based on a sliding scale. And in a sliding scale, the number of units of insulin will depend on the acute check immediately before meals. Insulin administration, how and where to inject. The structure of insulin is such that it cannot be administered orally or through the gastrointestinal tract. So there are two ways that you can administer insulin: subcutaneous and intravenously. IV administration of insulin is typically in the ICU setting. On a regular floor and at home, insulin is administered subcutaneously. Insulin being a subcutaneous injection, you administer it at a 45 or 90-degree angle. Unless the patient is super thin, I administer insulin subcutaneously at a 90-degree angle. Now, do you pinch the tissue before injection? Depending on your facility's protocol, you might or might not pinch, but I never pinch. Why? Because of the risk of self-stick injury. So if you click on this hyperlink, ditch the pinch, it shows you an article where they basically say that you should not uh, pinch before an injection because of the higher risk of self-stick injury. And where to inject, the preferred site is the abdomen, except for a 2-inch radius around the navel. And rotation within one anatomic site is preferred to rotation from one area to another to prevent day to day changes in absorption. In other words, uh, you rotate within the abdomen, right? Or you rotate within the area uh, upper forearm or within that thigh. You don't go from the abdomen to the thigh or to the upper forearm. So, like I said, common sites that provide good absorption, starting with the area of best absorption, include the abdomen, the deltoid, the thigh, and the buttocks. So, your first preference should always be the abdomen. Rotating sites. Insulin is administered subcutaneously. It is a protein substance. If taken orally, it is broken down in the gastrointestinal tract, rendering it useless. Rotating sites helps decrease lipohypertrophy or lipoatrophy. So rotating sites within one area rather than moving from one area helps decrease absorption variability from day to day. This can be done by injecting a new shot at least an inch away from the last injection site. At the hospital, you usually rotate between the left and the right. And you can find out where the last injection site through the electronic health record. So if it was the left, you do the right, and vice versa. Remember that insulin is a high alert medication. Medications that are associated with the highest risk of injury when used in error are known as high alert medications. Insulin has long been identified as belonging to this group of medications. According to a 2000 survey of pharmacists and nurses conducted by the Institute for Safe Medication Practices, intravenous insulin ranked first and subcutaneous insulin ranked ninth among nearly 40 drugs and drug classes identified as high alert medications. What are the types of error in insulin administration? A variety of error types have been associated with insulin therapy, including administration of the wrong insulin, improper dosing, such as underdosing and overdosing, dose omissions, wrong route using intramuscular instead of subcutaneous, improper patient monitoring, and administration of insulin that is not well coordinated with meals. These errors result in serious hypoglycemia or hyperglycemia. So, what do we mean when we say insulin administration that is not well coordinated with meals? You know that you're supposed to do an AccuCheck before meals. The question now is the sequence AccuCheck first, meal second, and insulin last? Or is it AccuCheck first, insulin second, and meal last? In the hospitals, nurses wait until meal trays are in front of the patient before they administer insulin. So the answer is 1 AccuCheck, 2 meal, and insulin is last. Because what happens if you administer insulin without the meal, you run the risk of hypoglycemia. You want to make sure that the patient is about to eat or has had just a meal before a subcutaneous injection of insulin. Many facilities require that two nurses be present in the administration of insulin. So nurse A will show nurse B the insulin syringe to confirm the precise number of units and the insulin vial to confirm that the correct insulin product is administered. But in this recent literature review, they found that administering insulin or rapid acting insulin 15 to 20 minutes before food would provide optimal postprandial glucose control. Data show that there is a reduction in post-meal glucose levels of approximately 30%. They also found that less episodes of hypoglycemia when meal insulin was taken 15 to 20 minutes before a meal compared with immediately before the meal. Importantly, there was also a greater risk of postprandial hypoglycemia when patients took rapid acting insulin after eating compared with before eating. So the moral of the lesson is you follow your institution's protocol. It takes time for studies to get implemented in the clinical setting. For exam purposes, we are going to follow this sequence. 1 AccuCheck, 2 meal, third and last would be insulin. For clinical practice, you follow your policy. This is a table that shows the onset and peak times of insulin. The onset of rapid acting insulin ranges from 10 to 30 minutes. And then the peak ranges from 30 to 90 minutes. The onset of short acting or regular insulin is 30 to 60 minutes. And the peak of regular insulin is 2 to 5 hours. Why do you need to memorize the peak and the onset? Because you want the onset to coincide with food intake. In other words, within that onset period, the client must eat or must have a food intake. During the peak, the nurse needs to monitor signs and symptoms of hypoglycemia. So that's the reason why you need to know by heart the onset and peak times of rapid acting and regular insulin. These are the onset and peak times of intermediate and long acting insulin. Recently at Southeastern Health, I noticed that they are using less and less of insulin pens. I can only venture a guess that it's because of the cost. At any rate, you should know how to use an insulin pen. Click on the link here to view a 4-minute video on the correct administration of insulin. So, what are some of the principles? First, you need to make sure that you have the correct insulin. The insulin pens look confusingly similar, but these products are different. Um, like this one is a Novolog, this one is a Levemir, and this one is a mix. So first, you need to make sure that you have the correct insulin. Second, you need to make sure that the pen belongs to your patient. In other words, you cannot use one pen for multiple patients or exchange pens between two patients, even if they're exactly the same type of insulin. Third, you need to make an air shot of 2 units to make sure that you are injecting insulin and not air that is in the syringe or the pen. When you are doing an air shot of 2 units, you need to hold the insulin pen 90 degrees vertically with a needle pointing up and the injection button down. Fourth, you need to stab the patient with sufficient force uh, to make a dent in the skin and deliver insulin subcutaneously. Because if your technique is too light, the insulin will just spill out. So it has when you stab the patient, you need to stab the patient with sufficient force that it creates a dent. Like I said, insulin pens may be expensive, so there may be occasions when you need to draw insulin from a vial. So the first thing that you need to do is to get another nurse to witness. Then you need to see that you have the correct insulin product and have the second nurse to confirm. Then you need to select the correct syringe. The only syringe that you will use for insulin administration is called an insulin syringe. You cannot use any other syringe. Why not? Because the calibration on the insulin syringe is in units, whereas all other syringes are calibrated in milliliters. 2 units of insulin is not equivalent to 2 milliliters. How do you know that it is an insulin syringe? It says on the syringe, insulin. There's and also the calibration is in units. So you know that it's an insulin syringe if it says there insulin and the calibration is in units. So syringes come in different sizes, as you can see here. There's an insulin syringe that holds 100 units, another syringe that can hold 50 units or 30 units. So which insulin syringe should you use? The smallest syringe that can accommodate the order. So if the order is for 20 units, you use the 30 unit syringe. You don't use the 50 or 100 unit syringe. The reason? Precise measurement. That's the reason. So, like I said, insulin pens may be expensive. And so there may be occasions when you need to mix two insulins from a vial of an NPH insulin and a vial of regular insulin. So, what do you do if you need to mix insulins? Click on this hyperlink to review how to mix insulins. It's a 4-minute video. Two of the more important things to remember are you draw out the regular insulin before you draw the NPH insulin. And you never mix glargine insulin with any other insulin. This is a summary of the steps when mixing insulin. Please read this carefully. The order calls for 10 units of NPH and 5 units of regular insulin. Note that the order can be any combination of units of NPH and regular insulin. So it could be 8 units of NPH and 4 units of regular insulin. I'm saying that because a former student incorrectly assumed that 10 units of NPH and 5 units of regular is standard, as a standard order, and it is not a standard order. That's the end of this lecture number 5. I just wanted to remind you that anytime you see an underlined text in any of my videos, assume that it is a hyperlink to a YouTube video. And you should always, always, always watch those videos. I pride myself in saying that I'm a lazy person, so I won't make you watch any video if I don't feel that it is important for you to watch. I may or may not ask questions from those videos, but know that these videos are important for you to watch for a smoother transition into your role as a registered nurse. If you found a better video, I really would appreciate it if you would be kind enough to send me a link. And if you noticed an error in the video, please feel free to email me. Thank you.